Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is posterior graft host malapposition. In this slide, you can see the OCT anterior segment cross section. At the junction of the graft and the host, the thickening is crossing more than 500. In fact, if you see over there, it has gone beyond 1000 micrometer. So what is this 400 micrometer under it? Let's see another. Even in the second slide, you will see this, that this something is hanging at the junction of the graft host posteriorly. So these things can be observed in post PKP patients. So what is this thing which is measuring 450 micrometers and increasing the thickness of the graft host maybe 3 times? There can be different scenarios. What is this and how it happened? But this is basically the remnant of the host tissue posteriorly, which has been marked with a green circle. There are no anterior synechiae. Angle looks fine, but the junction posteriorly is not smooth. This is a possible complication. It can happen, especially in PKPs. So what could be the different scenarios, how it can develop? Today we will study this. One scenario is that it was a case of keratoconus. Surgeon attempted DALC. Graft punch was done routinely, partial trephination was done, air bubble dissection performed, and while doing decimus membrane dissection, it ruptured. So surgeon converted to PKP. This is one scenario, possibility. But at this stage, doing trephination in a cornea with ruptured decimus membrane is not easy. Maybe he has used scissors, again used trephination, and he completed his surgery in the normal way. This is one scenario. The other scenario is that in routine PKPs, a study was conducted by Kesserman and was published in British Journal 2008. 60% of patients had this complication in planned penetrating keratoplasties. In 2013, a study was conducted by Nursel Melda and published in Clinical Ophthalmology. They mentioned ledges were present in keratoconic eyes and steps were found at posterior junction in pre-op endothelial dysfunctional eyes. And his results of finding this malapposition was also 60%, as it was documented by Kesserman. So whatever the scenario was, this is a complication. It shows us the importance of OCT anterior segment, that how important it is to calculate anterior chamber depth, ghost, host and graft junctions, anterior chamber angles, anterior chamber depth, any synecdoche formation. All these information can be gained with OCT anterior segment, and it should be done routinely in post PKP patients. Thank you.